Hi, I'm Vic Perri and welcome to another edition of QHealth. Now, the last couple of sessions we had Beng Eu talk about gay men's health, and we did mention in the first episode that we are going to cover other populations of the queer community, and of course one of them being lesbians. Now, we have two esteemed GPs on our program today, Sarah Burrows and Ruth McNair, both from Carlton Clinic. Now, today, because this is the first one that where we are going to cover lesbian health, we'll do a sort of very general overview of some of the main issues that lesbians deal with. Now, what are some of the issues that actually distinguish or that are different or pertain to lesbians more than, say, heterosexual women?
I think it's important to look at the differences between lesbian health and women's health in general, particularly relating to issues of discrimination and the assumption of heterosexuality. That can particularly be a problem with women going to see a GP, and the issue of disclosure, whether they reveal that they're a lesbian, and often they fear to do that, they won't do that, and then certain problems with their health may not be discussed. Other differences are increased mental health problems in lesbians, such as anxiety and depression, also increased substance use, and also more risk factors for certain cancers like breast cancer and cervical cancer.
What causes that? What are the risk factors then?
With cervical cancer, the biggest risk factor is the human papillomavirus, and that can be transmitted sexually. So, also smoking is another one, and not having regular pap smears. So that's another issue, is that lesbian women are less likely to attend for screening.
And what's the influence? I mean, why does that occur? Is it something to do with the community? Is it a context that lesbians live in?
Yeah, it is really. If you've had a bad experience with a provider and then you have some fear that that's going to happen again, you're much less likely to go and get a pap smear. Or if you've had if you've gone to get a pap smear and the provider said, no, you don't need one, and the lesbian says, well, hang on, I've been told I do need one, and now this person is telling me I don't. It's a pretty difficult situation to be in.
So there's a lot of myths going around that lesbians don't need pap smears, that lesbians can't get STDs or are much less likely to.
Is a cause of that almost because there's been such an emphasis on sexually transmitted infections and HIV in particular with gay men, and all the health promotion that's been done has focused on gay men? Has all the sort of resources taken it away from lesbian health?
Yeah, look, I think that's one issue that, and lesbians too have been very involved with caring for gay men with HIV/AIDS, and that's been part of the scenario in our community.
So busy they've forgotten to look after themselves.
Well, yeah, and as Sarah said, there's this assumption that as lesbians we can't catch STDs, sexually transmitted infections, and yet we know that we can. We're just as likely to get various STDs.
What are some of the other issues?
Mental health we talked about. Do you want to expand on that?
Lesbians are 2 to 3 times as likely to suffer from depression, anxiety and suicidal ideation, or having thoughts about suicide. And a lot of that relates to the discrimination. Also, lesbians are more likely to have suffered some kind of abuse in their life, so that'll increase that as well.
Is that abuse related to their sexuality? Sort of dealing with sexuality?
It could be, but all other forms of abuse, sexual abuse, incest.
And what about domestic violence? That's another issue.
Yeah, well, that's something that I guess it's another myth that women can't perpetrate violence against each other. But actually we can see in our community in Australia and overseas that there's plenty of domestic violence in same-sex relationships, both male and female. It may look different, you know, it may be more an emotional abuse issue rather than a physical abuse, but it's still abusive.
That's right, because it can be really subtle, can't it?
Yeah, it can, and yet, you know, damaging, just as damaging. So, and the community is afraid to talk about it too, because we don't want to stigmatise our relationships to the outside world. But now, I mean, there's a lot more information about it and more support and some specific lesbian support for DV.
Well, can the media help there? I mean, we're obviously doing it by doing this program. Is there enough support from the general media? Because whether it be press, radio, whatever, there's always coverage about certain aspects of our community, like venues and parties and everything else. Is there enough about health?
No, I don't think there's enough about women's health in the lesbian community. You know, that really needs to be beefed up. And there hasn't been much funding, so we're a bit stuck there, but it's starting to happen.
What are the prospects there, about the funding from government for lesbian health?
Well, there's been a fantastic influx of funding to the Gay and Lesbian Health Victoria, which is a new unit set up to not provide services but to gather together information and to start developing pamphlets and other and web-based materials for the community. So that's going to be a fantastic resource that's there for GLBTI, so the whole queer community.
And that'll sort of give information about this particular services or where women can go for specific issues.
That's right. So, you know, there is, for example, a domestic violence safe house for women in lesbian relationships, and that sort of information will be on the website, easily accessible.
That's great. Okay, well, that's all we're going to do for now. It was sort of quite a general overview there, but we will in future cover more specifically particular issues pertaining to lesbian health. So thanks very much, Sarah Burrows and Ruth McNair. I'm Vic Perri, and that was another edition of QWeekly QHealth on QWeekly, and we'll see you next time.
Thank you very much.
Hi, I'm Vic Perri and welcome to another edition of QHealth. And as usual, I've got the lovely Dr Beng Eu with me. How are you, Beng?
Really well, Vic.
Tonight we're going to talk about transgendered issues. Now, it's quite a large area of discussion, but we'll do what we can in the 6 or 7 or so minutes we have in this segment. Firstly, what is transgendered, or what does it mean?
I think this is where there's a bit of controversy about how people define transgendered. Strictly speaking, I suppose the medical term for the overall thing is gender dysphoria, which is still considered a mental illness, like homosexuals were in the past, sort of thing. And the strict definition is about people who want to change their gender physically. But I think our general understanding now is more about people who are probably not comfortable completely in their gender that they were born in. I suppose that's probably a general way of describing it. So I think it covers people who might want to dress as the opposite gender, up to people who might want to have physical characteristics of the opposite gender.
So it's about sort of challenging that binary construct that we're sort of brought up with knowing about the male-female, that that everyone's either male or female. It's about a sort of more varied sort of linear scale.
Yeah, absolutely. I think this is how people describe it. It's like Kinsey's scale about homosexuality in the 50s or 60s that he did, where he found that very few people were exclusively heterosexual or homosexual, and most people were somewhere in between. Same thing, I think, with genders. I think we're finding more and more that a lot of people fit somewhere in between. It's not black and white, as you said. It's not one or the other. A lot of people are, but there are a lot of people who are somewhere in between. And I think more and more now with transgendered issues, we're talking more to people about whether they want to fit into one extreme of the scale or not. People can choose to be in between the two and not feel like they have to conform completely.
And is that for the rest of their lives, or can people sort of have a feeling what gender they want to be at different stages of their life?
I think that's difficult to answer. I mean, for some people it would be for the rest of their lives, but I think there's certainly people who might change their minds or feel differently at different times of their life. And this is one of the difficult areas in terms of having gender reassignment surgery, people having surgery to change their physical characteristics, because there's a whole issue of if people can't decide for the rest of their life they want to be the other gender, then they need to maybe not go ahead and have the surgery. So it's quite a big topic to actually consider.
And with sexuality, a lot of people make assumptions and link the two, and they are two very separate things, aren't they? Gender and sexuality, and they don't necessarily.
Absolutely,
relate, do they?
absolutely. I think you're right, and I think especially in the general straight community, often sees what they think is a man dressed up as a woman, and obviously think they're gay and all that. And it's a totally separate thing, and how you identify your gender is totally different to who you're attracted to, and they're two totally separate things. And in some ways too, I think I know for a lot of gay men aren't very tolerant of people who are transgendered, and it's a real pity because it's a separate thing. They're just attracted to men, but they see that they're normal in that they're a male, whereas transgender people don't really fit into those categories.
And that what you've just said talks about the sort of prejudice that's contained within the queer community, because that prejudice is there,
absolutely. I think that's very sad, and especially I think in the queer community where so many of us have been sort of in some ways persecuted or excluded from the general community. I think it's very sad to exclude others from our own community as well.
So with transgender people, what are the particular health concerns that pertain to gender?
Well, I think there's so many health things we need to consider, but for me they come under two large areas. One is firstly the mental health, and I think someone who's transgendered obviously goes through a lot of mental anguish. A lot of them get very depressed because they're trying to sort out their gender, and often it's a very, very difficult thing to accept or even find out about. So obviously people are very disturbed over all that, and also because of being transgender, quite often their relationships break down, they've got rejection from family, all that sort of stuff, which then can again cause depression as well. And then there are all the other health issues related to their chosen gender, whether it's about hormone replacement to change their gender, whether it's about surgery. And it can be confusing for doctors to actually check transgender people for appropriate health things, because physically they could be still one gender that need to be checked for that specific gender health problems, and emotionally they might be another gender. So it's quite confusing to actually deal with. So they need to be aware that they need to go to doctors who are actually familiar with the issues associated with transgendered people.
Well, in terms of services and support, then they do exist.
Yes, I mean they do exist. I think the best thing for someone to do if they need to get some help or talk to someone is at least, for example, find some of the clinics that are listed in the queer community guides or also guides and stuff like that, and talk to someone about it. I think the biggest problem for some people is that they have no one to talk to about it, and for some people is they just want to cross-dress and they're worried that means that they want to be the other gender, and it's not always the case.
Well, there's another edition of QHealth. If you want more information about tonight's topic or any other that we've covered in the past, or if you actually want to hear more about a particular topic we haven't covered, just email us here at Beng TV. Thanks, Beng. We'll see you next time. Hi, I'm Vic Perri and welcome to another edition of QHealth. And as usual, we have our resident Dr Beng Eu. Welcome, Beng.
Thanks, Vic.
Tonight we're going to sort of very briefly cover mental health, and it's something we did mention in the first or second QHealth edition. Why is it becoming more important, and particularly why in the queer community?
I think things like depression are often very hidden. And I think the community in general is realizing now that there is a lot of depression about, but it's not talked about and it's not identified very often. And I think in the queer community, there have been lots of studies showing that depression is much more prevalent in the queer community as well. I think a lot of the issues is about coming out for the queer community, coming out and accepting themselves and being rejected by the general community, all that contributes to people feeling depressed or just feeling having a lower self-esteem about themselves. So I think that accounts for a lot of why the queer community has more depression in it, I think. I'm not sure what you think, because you've had quite a experience probably in the community as well.
Well, I think a lot of people, when they talk about internalised homophobia, for instance, it seems to be something that people blame themselves for, and we know that it's really all about the rejection and the non-acceptance from the environment, whether it be family, friends, workplace, or society in general, that's really the cause of internalised homophobia. It's not something that develops within you on its own, is it? So I suppose curable, isn't it? So
exactly.
If the world was a place where being gay, bisexual, lesbian, transgender, or anything, if there was totally accepted, it wouldn't be such a big problem, would it?
Exactly, it makes a big difference. And for example, like youth suicides, I think sexuality is a significant issue and overrepresented in youth suicide. So it's something that I think we all need to be aware of and try and identify and help people through if we think they're in trouble.
The best thing that people can do is support.
Yes, that's right. I think it's
so with we've heard of figures, for instance, particularly in youth suicide. What sort of figure is touted as being a percentage of youth suicide being attributed to sexuality? I mean, they talk.
I'm not sure. I haven't seen the actual figures. I don't know if it's broken down that precisely. Really, I don't know if someone's giving you a percentage compared to normal population, but. Everything I've read says that's overrepresented in youth suicide anyway.
But there's bound to be a number
that
are attributed to kids dealing with their sexuality.
That's right, absolutely, definitely.
Yeah. Now, what about association with drug use? I mean, the sort of psychosis. Well, actually, I mentioned the word psychosis. What does psychosis mean?
It's a bit hard to describe, I suppose. I suppose psychosis for most people is just being a bit mad. People who have ideas that aren't real, people who could be paranoid, people who are hearing voices, even all that sort of stuff. And in a general term, I suppose that's psychosis, and it's sort of I suppose in some ways a serious mental illness, and it's one that's more visible because people behave quite differently and quite sort of in an abnormal way. I think drug use and depression and psychosis are definitely related. Again, lots of studies showing that use of recreational drugs, can lead to depression in the short term when people are coming down from drugs, and in the long term too. There's some studies that indicate that probably, for example, ecstasy use can be attributed with depression later on in life as well. So
there could be a period of time between a person stopping the use of the drug, perhaps years, and then all of a sudden develop symptoms?
Yes, that's possible. I don't think there are a lot of clear studies, but I think there's certainly some indications that might happen later on, especially someone who uses it a lot. And because the recreational drugs play around with the chemicals in the brain, that later on they're much more prone to depression, and they can be also harder to treat later on. And certainly with amphetamine drugs like crystal and stuff, there's certainly what we call psychosis associated with people who are using a lot of amphetamines or speed, and people can get quite sick with it. And I think we've all seen people get into trouble with that too.
Do you see, I mean, there seems to be an incredible amount of controversy now about crystal meth. Do you see it as big a problem as it seems to be, and is it something that's going to be affecting people in the future? For instance, we just mentioned if someone's is taking a lot, and if they're sort of at their younger years, but then they stop, are we going to see in 10, 20, maybe 30 years' time an explosion or a great increase of people in their later years having problems that would be attributed to past drug use?
It's a very good question. I think most people expect there will be some consequence of heavy drug use, but I think no one knows how much someone has to use before it becomes harmful in the long term. So I don't really know. I expect we would to some extent. And I think a lot of the recreational drug use has really been much bigger probably from the 80s onwards. So we haven't had enough time to really see like 30 years down the track whether it's significant or not. And I suppose for the people using now, there's no way of finding out. We have to wait and see.
What other mental health issues? I mean, we mentioned depression. What other major
I think
issues?
the thing is, I mean, obviously the queer community are as susceptible to other mental health problems as well, you know, anxiety disorders, bipolar disorders, everything else, schizophrenia as well. So it's something we just need to look after ourselves about, I think, and need to get help for ourselves or people we know who have mental health problems, who might need to access mental health care either from doctors or counsellors.
So if people wanted, where could people get access services or support?
I think they should probably either ring up a counselling service like one provided by the Victorian AIDS Council, or if they have a clinic they're familiar with, they should ask maybe their doctor about it.
All right, that's all we have for tonight's QHealth. If you want more information on tonight's issue or anything we've covered in the past, or if you want to hear more about a topic we haven't covered yet, just email us here or call us at Ben TV. I'm Vic Perri and we'll see you next time. Thanks, Ben.
Thank you.
Thanks, Amy. Hi, I'm Vic Perri and welcome to another edition of QHealth. And of course, welcome again, Dr Beng Eu from Prairie Market Clinic. Now, tonight we're going to cover HIV. Now, we can go on for hours and hours on HIV because there are sort of so many issues to do with HIV, but we won't. We will do that over a few sessions, but tonight we'll just do the very basics. Now, unfortunately, there are still people who don't know the basics, and even the simple question of what is HIV.
I suppose it's a good idea just to start back from the basics again. HIV is the virus that causes HIV infections and AIDS, I suppose, which was discovered some years ago. And I think it is important when we're starting to talk about this, I think we need to go back to how people can prevent it, how the virus is transmitted, before we start talking about the details about the illness or anything like that.
So what does HIV stand for?
It's a human immunodeficiency virus, and obviously it's just a name given to the virus when it was discovered in the 80s. And basically it's a blood-borne virus, so it's a virus that's basically transmitted from person to person through exchange of body fluids, whether it be blood or semen or something like that. So I suppose that's something it's worthwhile keeping in mind, that, you know, it has to be transmitted from person to person. You know, it's just not the sort of thing you can catch from somewhere else, and all those myths about
so
catching
you can't
from
catch it off a toilet
seat, the pool,
or a coffee
all
mug
that stuff. That's right, exactly.
Right.
You can't quite catch it that way.
A blood-borne virus, meaning that it has to be blood to blood. So even kissing someone or...
Yeah, it has to cross over. So I suppose when people talk, a lot of people ask about kissing, and that brings on things about oral sex and stuff. I mean, generally kissing, there's no exchange of fluids. You have saliva, but then as long as, you know, all the membranes are intact in your mouth and everything, it doesn't really cross over as such, I suppose. But potentially, if people are bleeding or something, or they've got cuts in their mouth, then potentially there can be some crossover. So, but it's, you know, I don't think I've ever heard of anyone that thinks they've picked it up from kissing ever.
Right, so when you look at the stats over the years of how people have caught it,
yes,
there really hasn't been any cases of someone catching it, say for instance by someone giving or receiving oral sex.
No, there's nothing definite about oral sex either. Again, oral sex is one that's thought of as low risk. And again, potentially there can be a risk because if someone has semen in their mouth and they've got a cut or something, it can enter. We've probably got a handful of people that think they might have picked it up that way, but it's very rare generally. So generally it's still transmitted through unprotected anal or vaginal sex. And basically, I suppose that's the bottom line. That's still the most common way that people pick it up.
Yeah. And is that a definite thing as well? I mean, or even then, it's not necessarily 100% guarantee. Not that I'm suggesting that that's okay to do, but it's an increase in risk, but it's not necessarily 100%.
It's the highest risk, but it doesn't mean that when someone does it, they'll pick it up straight away. You know, it depends on lots of factors. Depends on what the sex is like, how long they have sex for, you know, how much fluid is transmitted, their body's immune system, how much virus is in the person that's already infected. So yeah, there are lots of factors that come into play anyway.
Now, getting back to HIV and someone, say, living with the virus, now that's quite different to AIDS, isn't it? What's AIDS and what does that stand for?
I mean, AIDS was actually just classification from the 80s, and it really applied to people who were actually had acquired immune deficiency syndrome, so people who are quite sick in hospitals with infections and stuff like that. So we've stuck to that classification where AIDS really defines someone with a very lowered immune system, for example, presents to hospital with PCP pneumonia, something like that, and they classify as AIDS. I suppose it's just, it implies that someone's health is probably affected more by the virus than someone who's just infected with HIV, where they have the virus but they're essentially healthy.
And so a person with HIV can be healthy, like can live
definitely. I mean,
for a number of years.
And I think, as far like you know too, like nowadays, I think a lot of people with most people with HIV are basically healthy, working in community, you know, just doing things like everyone else is anyway.
So it doesn't necessarily lead to AIDS.
Yes, that's right. Exactly. And especially nowadays with all the treatments and stuff, I think we're more hopeful that we can manage HIV for much longer periods, and you know, people might not develop AIDS for long periods of time.
So it's become a chronic sort of
yeah,
manageable
much more
disease.
manageable sort of.
Right. But there are still issues though with treatments, isn't there? So we can't sort of make light of the fact that.
Well, exactly. You don't want to minimise it too much, because it's still a serious condition and it still lead to AIDS and ill health and everything else. And some people don't react to medications well. Some people actually succumb to the virus much quicker than others. So it's still a serious condition. So it's still something you'd rather prevent.
So we'll talk more about treatments another time, because that's certainly a lot more that can be covered there. What about so people with HIV? What about discrimination? Is that something that's still an issue? That stigma and discrimination?
I think it is, and discrimination on several different levels. I think on personal level with friends and family and all that. I think a lot of people feel quite discriminated against, and also obviously on like professional work levels and stuff. And I think because there's a lot of misunderstanding about HIV, and one thing is about how it affects your health, and secondly, people make judgments about who you are. I think if someone's HIV positive, they wonder why, and people worry too much about how people contract things and all that. So yeah, there's a lot of discrimination about still.
And we'll probably talk more about that another time as well. We're sort of running out of time, but for people who do want to get more information about HIV and AIDS or treatments, people who want to know about the various services, because there are a lot of services out there for positive people and as well as people at risk or who just want to know. You can call the Victorian AIDS Council Gay Men's Health Centre. That's it for QHealth. Thanks, Beng.
No problem.
And we'll see you next time.
Thanks very much.